Patellofemoral pain syndrome can be easily treated conservatively, but sometimes when conservative treatment fails, we have to proceed towards the surgical treatment. Now, surgical treatment of patellofemoral syndrome is actually directed at the underlying cause. As I told you, there are multiple differentials should be kept in mind when we are dealing with anterior knee pain or patellofemoral pain syndrome. Therefore, if the problem is malalignment, then we may have to go for some form of realignment surgery or realignment osteotomy. There are different osteotomies or surgeries which may be required. For example, if you look at this diagram, in this, the patellar tendon is divided into the half and is actually medialized towards the anterior medial aspect of the tibia. Now, this is usually accompanied by where the problem is patellar instability and increased patellar tilt, leading to patellar ball tracking and problem of the anterior lateral knee pain, leading to anterior knee pain syndrome. If that is the problem, one way of dealing with it is actually in creating a more medialized pull of the patellar tendon. The other way out is that instead of going with the patellar tendon, usually we use semitendinosus and gracilis as a graft, and we attach it towards the on the anterior superior lateral aspect of the patella. By this is acting as a pull, so the force is actually being exerted by the semitendinosus and gracilis, which keep the patella more medialized over this side rather than being and stabilizing the patella. Therefore, if the problem is patellar instability due to malalignment, we have multiple options, like we can go for osteotomy, or we can go for redirectional procedures in which we can either medialize the patellar tendon or use semitendinosus gracilis to actually pull the patella medially. Other options which may be required, which could be bony procedures as well. For example, other options could be arthroscopic. Now, instead of if it's outer bridge low degree classification, for example, it's only softening or thinning on the MRI, are there only fissures, we may also go for only debridement of the arthroscopic. But if it's outer bridge grade 4 in which there's actually this exposed subchondral bone, therefore microfracture technique arthroscopically can be used to actually go for some form of a chondroplasty or autologous chondrocyte transplantation along with the lateral retinacular release as well. Isolatedly, chondroplasty is effective in the case of its problem is in the arthritis of the medial lateral femoral condyle, but usually with patellar side, if the subchondral bone is exposed, you may have to go for some form of lateral retinacular release, so to decrease the stress and overload due to deranged biomechanics as well, along with the chondroplasty of the undersurface of the patella. Then there are certain bony procedures like osteotomies. One of the most commonly performed procedures is actually the McMitt tibial tubercle advancement operation. This is a procedure in which actually the tibial tubercle is advanced anteriorly as superiorly. And how it is done, if you see this diagram, this is the lateral view. This is the patient incision is given on the tibia, on the anterior medial aspect of the tibia, and osteotomy is done by cutting the tibial tubercle up to 8 centimeter over here. And once this is done, the patellar tendon is actually, before it was here, now it has actually gone little anteriorly advanced. And how it is anteriorized? By putting either the graft over here or putting any plug. With this, usually the most common form of plug which can be done is form of a Eiley crest graft, which can be placed between the anteriorized tibial tubercle and the tibial bone itself. And once this heals over a period of time, as you can appreciate it over here, it's healing over the period of time. And now if you see, the initially it was pull was this, actually the pull of the patellar ligament is acting in this direction. Therefore, the patella, which was present like this initially, now it has become like this, and therefore there is less likely to actually it's less likely that this patella would actually just rub against the surface of the trochlear groove. Therefore, even if the subchondral bone is exposed, there would be less chances of painful sensation, because now the two bones are not actually rubbing against each other. Rather, this patellar biomechanics is being changed in such a way that it can easily glide past the trochlear groove. And you can also appreciate that there is some degree of patella alta as well. Once the patella becomes higher up, all this actually takes it out of the trochlear groove. Therefore, chances of actually rubbing against the trochlear groove is minimized. Other option is patellectomy, or even other certain osteotomies such as Elmsile trilar surgery is also can be an option as well. Patellectomy is almost a last resort. This is usually not done and rarely done if done so. And usually now it's done that if you have to go for patellectomy, go for partial patellectomy, because quadriceps tendon function cannot be later on restored. There's massive decrease in the quadriceps tension actually, and which results in kind of an extension lag if complete patellectomy is done. Other option could be like Elmsile trilar procedure or Ferguson osteotomy as well. If the problem is underlying patellar instability leading to anterior knee pain syndrome or patellofemoral pain syndrome, then we can go for anterior medialization of the tibial tubercle in form of a Fulkerson osteotomy or Elmsile trilar procedure or osteotomy as well. In all these, what is important to know is that whenever a surgeon is deciding on surgical option, it needs to take into account all the factors which are patient specific. For example, patient may be having instability, patient may be having underlying chondromalacia, patient may be having underlying knee problem as well, or there could be underlying malalignment. Depending upon what exactly is the problem with the patient, which is actually causing this issue in leading to patellofemoral pain syndrome, what is important is that you need to tailor your surgery accordingly. If the patient requires an osteotomy, we can go directly for the osteotomy. But if the patient can be better and patient can have good results, and patient can be given a pain-free knee with certain soft tissue procedure, we can go for certain redirectional procedures, which is involving the patellar tendon or semitendinosus gracilis muscle as well. All these need to be taken into account when we are dealing with patellofemoral knee pain syndrome.